Hi, and welcome. This telehealth series is presented by the NOWS New Mexico Quality Improvement Initiative. This initiative focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. This 12-part curriculum is designed to give providers, nurses, care coordinators, and community members content-specific training and education with opportunities for care consultations around this focus. And today I'd like to introduce our speaker for today, which is Dr. Larry Lehman.
Thank you very much. I really appreciate being invited to talk on this topic. I'm a professor of family medicine and OBGYN at the University of New Mexico. One of my major focuses now has really been the perinatal effects of the opiate epidemic. I work with the New Mexico Perinatal Collaborative. I'm on our part of the NOWS initiative, and I'm the medical director of the Milagro program, where we do prenatal care for about 200 opiate-dependent women a year. This talk here, which is going to be on prenatal care and medication-assisted therapy, really describes a lot of what we do during our Milagro clinics on the medical side. Of course, the context is much broader, and that's why we have other talks in the series that discuss substance abuse counseling, which is integrated into the program, discussions regarding parenting, breastfeeding, and such. But here we're going to focus on a much narrower topic, which is going to be the medication-assisted therapy and ways that prenatal care is altered for women who are on buprenorphine or methadone. One issue that comes up is I think, as most of us know, some women don't even get any prenatal care. Some women arrive late to prenatal care. Often that leads to sort of a judgment that they're not caring about their pregnancy or the babies. I think it's important to put it in context. It's very hard for the women to come, show up, talk to a physician, deal with what they know is a stigma about not only opiate dependence, but about being pregnant with opiate dependence. There's some mistrust of medical providers. Lots of fear about being referred to Child Protective Services, CYFD. They're in New Mexico, and many of our communities don't have easy access to medication-assisted therapy, so we might be talking about somebody driving several hours who's often just not a great financial means and able to do that. And then we lack providers with experience with prenatal care and medication-assisted therapy, and we're hoping that we're going to be helping with the provider partners with this series. So medication-assisted therapy is really the mainstay of treatment of opioid dependence in pregnancy. We don't recommend withdrawing completely, risk preterm labor, miscarriage, stillbirth. All those are actually sort of the classical worries. They're relatively low risk. What's at a quite high risk is the risk of relapsing with risky behavior, the idea that they wind up going back on heroin. Some studies have shown that when you withdraw women, 90% or more wind up being back on heroin or whatever their opioid of choice was. Opiates don't appear to be teratogenic. There's some studies that have suggested that, but overall most don't show that. There are risks of continuous opiate use, growth restriction, and neonatal withdrawal. One study shows that women who get on medication-assisted therapy have less risk of that than the women that are continuing to use heroin or prescription opiates. So just put it in the context here, I mentioned, abstinence-based therapy, which can work with counseling, peer support, social services, contingency management. And there are some uses. I don't want to say that it never has a role. A situation where a woman is on a very low amount of an opiate, she lives far away from a way that she's able to get care, that may be appropriate, but I would say it's for a very small proportion. Opioid antagonist therapy blocks the action of the opioids. These are being, used more and more in non-pregnant women. Naltrexone can be given orally, but it's not been studied in pregnancy. So we're again going to focus mostly on methadone and buprenorphine. So just to talk about, wouldn't it be best to get women off the opiates? Again, it's unlikely that they're going to remain drug-free. The opioid antagonist naltrexone is not really an option here, and if enforced abstinence is the approach, are unlikely to present to prenatal care. Their historical content is methadone maintenance therapy, has been the gold standard since about the 1990s. And so when we start talking, I'll focus on that and then get to buprenorphine. One thing to consider is that methadone is only available in less than 10 clinics in the state. They're by and large in Albuquerque and the larger cities. Buprenorphine can be much more accessible, and we'll go over a little bit on the risks and benefits of the two. And as far as the detox part there, the reason again that we're not supporting that is concerns about relapse. What are the studies that support the detox? And the reason that I'm emphasizing this is to most most lay people, many healthcare workers, that seems like it's the right thing to do. It seems that we don't want women to be using anything at all, or just substituting another drug. These studies here, one of them showed a 56% success rate over 6 years, higher than I mentioned, but that was only 95 women over 6 years, and we had no idea what the size of that population was, and were they somewhat cherry picking the women who could do best. There's a study that came out in 2016 that studied 300 women. 100 were rapidly detoxified. They were during incarceration, and there's actually ethical issues that come up with that. A letter that was published in response that I would agree with, where the idea of doing immediate detox on an incarcerated woman does not appear either humanistic, and it may have effects on the fetus. What does some ACOG say? ACOG is our OBGYN association. It says withdrawal from opioid use associated with poor neonatal outcomes, early preterm birth, and higher relapse rates. And so ACOG continues to recommend medication-assisted therapy as the standard of care. So benefits of opioid replacement therapy are numerous. Decreasing transmission of hepatitis C, HIV, and other infections that are associated with IV drug use. Decreasing activities associated with obtaining street drugs, theft, sex for drugs, and incarceration. We have a large proportion of women that are incarcerated for opiate-related issues, and they may not be simply possession, maybe some of these other activities. By being incarcerated, they're by and large not able to breastfeed, not able to be with their children. Just by being on the medication-assisted therapy, they can return to normal activities. They can work, parent, decreasing the risk of overdose death. And again, I mentioned simple drug detoxification has limited long-term effectiveness. One of the risks of drug detoxification also is that it's similar to what happens when the women are incarcerated. If they're detoxified, they come out and they start using, that's the highest risk time for an overdose. So that's good, but does it actually work? I mean, are there studies supporting that Matt does? And there are. Methadone use in pregnancy, increased use of prenatal care, decreased fetal and neonatal morbidity, and decreased relapse. So I hope I've convinced you that medication-assisted treatment is the way to go, and I'm going to go over now the two different forms. So the initially, if I was giving this talk 8 years ago, I really would have emphasized methadone as being the gold standard in the first-line therapy, and just continuing buprenorphine when we were on it. It's really changed over the last 5 years. Again, the ACOG opinion here supports the use of buprenorphine and mentions numerous advantages of buprenorphine: less risk of overdose, fewer drug interactions, and what I mentioned earlier, that our pregnant women can access buprenorphine much easier than methadone. But they're both good treatment options. In our treatment here in Albuquerque, where we of course do have access to both, we have about 2/3 of the women now are on buprenorphine and about 1/3 are on methadone. Here's a direct comparison between the two of them. So methadone is a full agonist, meaning it directly works to have an opiate effect. It needs to be dosed daily or twice a day. You can graduate up to where you take some of it home with you, but initially it requires daily dosing, which can be an issue with transportation. It's very tightly regulated. You have to go to a dispensary, which is like an ORT, an opiate replacement therapy, and there's few of those in any kind of smaller towns or rural areas. One of the big advantages of methadone, it's been used for a long time. We know what's involved with its use. It's been studied some long term. Buprenorphine is a different kind of a drug. It's a partial agonist and antagonist, and that means it both works to supply opiate effect to promote withdrawal, and it works as an antagonist, so it blocks opiate effect. So if a woman is on Subutex and she uses an opiate, she may have minimal effect from that. It binds very strongly, and so when the buprenorphine is given, it actually bumps off other opiates from the receptors. I mention that because it's important in how you need to start buprenorphine. You actually have to have the woman in some amount of withdrawal. If you gave your typical person who just used heroin 2 or 3 hours ago buprenorphine, she would be precipitated into withdrawal, similar with what happens with naloxone or Narcan, because she would have all of her opiates bounced off. However, if you wait till she's been in withdrawal, which usually means no opiates for 12 to 18 hours, then she'll feel better. It'll actually start treating her withdrawal. Buprenorphine requires it's an X license. Really, it's an X code on your license. It can be done through outpatient appointments. You can prescribe as much as 4 weeks at a time legally. In pregnancy, we're usually doing more like a 1 or 2 week time period. But a woman who's been on buprenorphine for many years and gets pregnant, we may actually do a month of therapy. So when we think about the baby here, they have different effects on the baby. Methadone and Subutex both don't have a dose-response relationship, although that's better studied with methadone. This is something that's taken a long time to sort out, and if you go back 10, 15, 20 years, there was an idea to try to get women on the lowest dose of methadone to help their babies not go through withdrawal. The Academy of Pediatrics in the past said you could only breastfeed if you're on less than 20 milligrams. None of that is relevant at this time. We're really encouraged that women are on whatever dose of methadone they need to stop their craving. The babies that are exposed as fetuses to methadone have worse peak of their withdrawal, as evidenced by the Finnegan scores, longer treatment and stay. It's been well studied that benzos, tobacco, as well as some antidepressants, serotonin selective receptors, worsen that withdrawal with methadone. With buprenorphine, benzodiazepines do the same thing. What the studies that are out there are showing is there's a small decrease in the proportion of babies that are treated when the moms are on buprenorphine and methadone, but there's a more significant shorter hospital stay and a shorter duration of treatment comparing buprenorphine to methadone. So I'm going to get down a little bit into the details of how we're actually using each of these drugs. So methadone, I mentioned, is through approved treatment clinics, treats both withdrawal and craving, long-acting, so it can be given once daily. Initially, the women come in, they're going to have observed daily dosing. Gradually, they'll work up to take home. It cannot be used by a physician through the office setting. I want to clarify that because sometimes we've had some confusion happening. A physician can prescribe it in any office as a drug for pain. So if there's someone who has chronic back pain, that can be prescribed usually at a lower dose, and that doesn't require them going through a opioid replacement therapy center. However, you can't use that as a way to be treating people in pregnancy. It violates federal laws to be using it for addiction. I mentioned that buprenorphine requires withdrawal. Methadone doesn't require withdrawal. It can occur in an outpatient setting. You need to attain a baseline EKG. There's QTC interval if it's prolonged. Has a risk of precipitating torsades, which is an arrhythmia, and even sudden death. So it's mandatory to get an EKG before starting. Depending on the number that comes from that interval, follow-up will be indicated. Initial dose, usually 10 to 30 milligrams, depends on the opioid use pattern. And on that first day, you can give another 10 milligram dose. So I'm talking about how women need to go to a methadone clinic for this. One thing that's important to mention, any hospital where a woman is in acute withdrawal, anyone can prescribe methadone in the hospital. So that's a different scenario. So you may be going, why do I need to know this? You need to know this in case you may be helping with methadone treatment in the hospital. Dose increase slowly, 5 to 10 milligrams per day, usually a maximum of 40 to 50 milligrams in the first week. It takes 45 days to reach the steady state. Further dosing is only based on symptoms of the peak methadone dose. And again, we're kind of doing this as slow increases here. Why are we doing it so slow? It has to do with the long half-life. So when you initiate methadone, it takes many days for the full effect to be seen. So if you initiate a woman on 30 milligrams of methadone and you continue that same dose, her actual level is going to rise. It's why there's been an association of methadone with overdoses. And if you prescribe it similar to you would with many other medicines, you're going to be in a dangerous situation. For instance, if you started a woman on 30 milligrams, she's still withdrawing, you titrate her up, and each day you go up by 10 milligrams, and in 5 days she's on 60 milligrams or 70, send her home. What then happens when she goes home for the next 4 or 5 days? Her drug level will keep rising, and she's at risk for fatal overdose from that. If a woman's using benzodiazepines or alcohol, she's at more risk for overdose. The metabolism is that during the third trimester, dose increases are often required. There's some preliminary evidence that it may be better to the fetus to do multi-day dosing, to have a dose in the morning and in the evening. That, of course, requires take-home dosing and really requires more research until we figure out the optimal way of doing that. One thing I mentioned here is that opioids and abuse, if a woman is started in an outpatient setting, it's very common that they will continue to use until their dose is increased. That has to be separated from relapse. I mean, the finding of a positive drug screen in the first week or 10 days is a fairly expected finding. It's not what we want. We very much are encouraging abstinence from illegal drugs, but given the fact that the initial dose doesn't fully treat them, it's a common issue. So what's different about buprenorphine? Partial opiate agonist of the mu receptor, escalating the dose doesn't give initially infinitely a higher effect, does decrease the euphoria and seems to be less sedating. So that's why when we contrast the two, there's going to be less of an issue with overdose with buprenorphine. It's very, very difficult to have a fatal overdose with pure buprenorphine. However, buprenorphine mixed with benzodiazepine certainly can cause a fatal overdose. So I mentioned earlier, you can precipitate withdrawal in those that are not already in significant withdrawal. This is why this is a tricky drug. This is why the FDA mandates additional training. To be able to prescribe this, you need to, as a physician, take an 8-hour course. Physicians, assistants, and nurse practitioners can prescribe. The current requirement is 24 hours for those classes of providers. And again, it's less dangerous than methadone, and that's one of the major advantages in pregnant women or other people. I mentioned the DEA license. The ceiling effect is important. The ceiling effect means less risk of overdose. And so we usually max out the dose at 24 milligrams. If a woman took 48 milligrams, she may have some effects from that, but she's very unlikely to actually have an overdose that was going to be fatal or even require a hospitalization. It's being used increasingly in primary care settings with men, women, pregnant, non-pregnant. There's increasingly a move to try to establish a primary care home. It decreases the stigma. So if you're going to a methadone clinic, you're driving to a methadone clinic, that's clear that that's what you're going there for. Some women are not comfortable doing that, particularly when their issue was prescribed opiates. And what we found is that they're much more willing to go to a primary care home, whether that's in the office of a family physician, obstetrician, other provider that's prescribing. So Subutex versus Suboxone, those are both trade names. And I usually actually try not to talk about trade names, but there's so much confusion between the two of them that I want to go over that a little bit. So Suboxone is the same as Subsol, which is a combination of buprenorphine and naloxone. Now, the naloxone only has one role. It doesn't affect at all the treatment when it's used sublingually as it's prescribed. But if a woman tries to inject it, the Narcan will block the effects of any opiates. And so it's a way of discouraging intravenous abuse. Subutex is pure buprenorphine. In New Mexico and most of the country, we're using pure buprenorphine in pregnant women. That's more controversial in some areas where buprenorphine has become a significant drug of abuse. That's happened in like the Plains, South Dakota. People sometimes ask me why don't I think that's such an issue here, and I think it has to do with our proximity to Mexico and the ready availability of heroin, which is cheaper in New Mexico. The naloxone does something else besides blocking it. It reduces the street value of the drug for use. All right, so let's talk a little more, and I've mentioned some of these before, but just to go over, what are the advantages of buprenorphine? One of them, it deals with not needing to go to a methadone clinic. Major one here is access for non-urban women. We have women that drive really far distances from Hobbs, from Texas, different areas. If they're coming for buprenorphine, I can give them 14 days worth. If they're getting a methadone dose, they're going to get one dose. Well, nobody can do that. Nobody can drive 8 hours every day for a methadone dose. There's a perception among women that it's easier to wean off postpartum, and I think that's true. One of the ways of getting people off of methadone is to substitute buprenorphine and wean down from that. We've talked already about decreased incidence and severity of neonatal abstinence syndrome. I think that's the main motivating reason why we're seeing, even in urban areas where methadone is available, increasing use of buprenorphine. And then the advantage is less overdose. All right, so let's talk a little bit about buprenorphine. So again, I emphasize that the patient needs to be in moderate withdrawal. Now, an interesting question is, where do you do that? Do you need to admit the patient to the hospital? Can you do that as an outpatient? Can you do it in your clinic? With non-pregnant patients, initially the inductions were by and large done in the outpatient clinic. Increasingly, there's been a use of home induction in those situations. With pregnancy, there's been concern about doing this as an outpatient in women that are over 22 weeks gestational age. There's been concern about risk for preterm labor, other effects if they have uncontrolled withdrawal. My own personal belief is that this is a problem that is actually rare. We're actually doing some studies here at UNM. Why do I think that's rare? Because these problems are relatively rare in women that are actively using heroin, withdrawing on a regular basis, when they don't have access, and we just don't see a mass of preterm births that are initiated from that. But at this point in time, most places are having women observed in the hospital when they're over 22 weeks. So you need moderate withdrawal. Once they get moderate withdrawal, they can give their initial dose of buprenorphine. That's a bit of a test dose. The symptoms should get better, certainly not worse. Then in another hour, we'll give another 4 milligrams, then another 4 milligrams in 2 hours. This dosing is what we're using for our heroin-addicted women. We're finding almost no one who's on heroin that needs less than usually 16, and so we're trying to go up pretty quickly to 12. We're more aggressive with increasing the dosing with pregnant women than with non-pregnant, partially because we're dealing with two patients. We're dealing with the woman, and we're dealing with the fetus who's presumptively experiencing effects of withdrawal also. We can even go higher than 12. We'll go up to 16, even 20 on the first day. As with a non-pregnant woman, usually 12 or 16 is going to be your ceiling for the first day. You can prescribe up to 32 milligrams. There's really no reason to be prescribing more than 24. 24 milligrams is blocking almost all the receptors. The general feeling is that women who are getting 32 milligrams are at high risk for just diverting the other 8 milligrams. And so we discourage prescribing more than 24. This is a slide that unfortunately can't really read here, but I just want to give you some idea how we evaluate their withdrawal. And if you print this out, you'll be able to use that. The COW score is relatively easily done, does not require any sort of extensive training to do that. It's based on symptoms such as myalgias, diarrhea, pupillary changes, and you can use that to assess withdrawal. If you see here it says moderate withdrawal is 13 to 24, we're usually trying to get women so they're somewhere like the 12 to 16 range and then starting them. We're really trying not to have women get into the more severe withdrawal. We have, besides the fact that it's extremely unpleasant, the effects on the fetus are unknown. And what we've seen when we initially started some of our buprenorphine inductions in the hospital is that if we went too slow, the women left. I mean, they left and went back out on the street to get heroin. So we try to get them out of withdrawal before they get into the moderate or severe withdrawal. Just a little data here to behind what we're having there. So this is the Mother Project study, neonatal outcomes. And again, it didn't show a significant difference in the percentage requiring treatment for NAS, but what it did show are really the other obstetric outcomes, but it showed that they required 90% less morphine, 40% less time in the hospital, and about 60% less time receiving morphine. And so these are the advantages for NOWS. And just to wind up a little bit on buprenorphine, outpatient possible below 22 weeks. Our current guideline is that after 22 weeks and during any incarceration to do it inpatient. Why are we doing it inpatient if you're incarcerated? Our concern is that the woman may not have rapid access to be able to contact a provider or get additional dosing. Moderate withdrawal. We do get baseline liver tests before we start. We get a urine drug screen before we start. What about if a woman is on methadone? So this question comes up to me probably a couple of times a month, where a woman has been on methadone, she gets pregnant, she does some reading or talks to some friends, and they say, oh, I heard it's better for the baby if you're on buprenorphine, and can I just get off methadone and be on buprenorphine? And that's not something that we offer here or really other places around the country. The problem is if you're on methadone, to actually get to that moderate withdrawal, you need to take, it can be minimum of 48, it can be 96 hours, it can be 5 days. During that time, the fetus is going through withdrawal. And so it's just not recommended to do that other than under a research study. Now, that's not an absolute. Let's say we had somebody that was in Albuquerque, but they were going to be returning to remote reservation in Montana where there's not going to be any access to methadone. We could do that, but we would plan on hospitalizing her, and could easily be a week or more. after the woman's been induced, we do weekly visits in Milagro until we feel like they're stable. Signs of stability, negative urine drug screening, she's going to counseling, attending her visits. We have a contract that we have the women sign before they're started on buprenorphine, which addresses many of those topics. So there's some women that are just at higher risk for different things: concurrent mental illness, domestic violence, homelessness. Tragicidity is not an issue with the opiate drugs. Alcohol is really the only major known substance abuse strategy. Pregnancy complications, to circle around a little bit on that. So with opiates, we mentioned growth restriction, preterm birth, tragicidity. I want to mention stimulants, and the reason I mention stimulants in a talk about opioid withdrawal syndrome is polysubstance abuse, which is a very common problem. A woman who is addicted to heroin, but also uses cocaine or methamphetamine, have to really determine, what the best way for her to be treated is. Many times, the opiate is the primary drug of abuse, and the stimulant is used when the opiate's not available, or once or twice a week. They'll largely do well with medication-assisted treatment. If the woman has an addiction, both to the opiates and having daily use for methamphetamines, that's a hard one. I haven't talked much about inpatient treatment, but that may be someone that they may do best with a 30-day inpatient treatment. The stimulants have different effects. One of the stimulant effects is a placental abruption, where the placenta suddenly separates, and that's something that doesn't happen with opiates. That's the reason why we're recommending induction at 38 weeks for active methamphetamine or cocaine use, and we're not recommending that for opioids. So how do we care for the women? The women, they're in the clinic. There's really a need for this to happen where you have a collaborative approach: obstetrical care, prenatal, postpartum, primary care, pediatric care, addiction specialists, substance abuse counseling, and methadone or buprenorphine provider. Now, sometimes, like 2 or 3 of these can be provided by the same person. It may be, though, that in the community there's going to be somebody who will do the prenatal care, someone else who will do the counseling, someone else who will do the buprenorphine. It's going to vary, but you need to bring a team together. That team, and a lot of hospitals, also needs to include nurses, anesthesia, and other providers. So what else do we think about in prenatal care? I mentioned we're mostly going to talk about MAT, but I want to just mention a few other things. There's a high incidence of intrauterine growth restriction. And we do growth ultrasounds. It's cut off on your slide there, but it's 28 and 34 weeks to assess for growth. We don't routinely perform antenatal surveillance for mothers who are stable. Antenatal surveillance refers to non-stress tests and biophysical profiles. If they are IUGR, we do initiate twice a week surveillance and usually follow them with Dopplers. If a woman does not have IUGR, does not have other issues, is stable, they just deliver a term. We do not routinely do an induction prior to 41 weeks for an opiate-dependent woman. Now, ongoing stimulant abuse, polysubstance abuse, unsafe social situation, we will sometimes do a 38-week induction, just feeling that it's safer for the fetus and the baby to be delivered. Well, thank you very much. I really appreciate that. If we were all sitting in the same room together, I'd be delighted to have an interchange in questions, but I do want to share my email here. I'm happy to answer questions both about, our program, specific issues, providers. We actually have a Milagro doctor on call 724. I think most of you may be familiar with the UNM PALS line. You could always ask for the Milagro physician on call. But for less urgent questions, send me an email. I'll be happy to respond or arrange to talk to you by phone. Thank you very much. Again, I appreciate being invited here and getting to share some information. We have a huge problem here in New Mexico in the country, and the more that we can bring people into collaborating, the better. So thank you very much for attending.